Takes a little while for all the numbers to come up. Hello, everyone. Hopefully you can hear me. We're going to give you a couple minutes here, 1 or 2 minutes, just for everyone to be able to join and get started. You are here for the Tackling Neighborhood Poverty to Improve Children's Health webinar from Build Healthy Places Network. And if folks have a chance who are joining to put into the chat box your name, your institutional affiliation, and where you're based, that would be great. I think it's always nice to see the geographic diversity. And we'll start like 2 minutes after the hour. Oh, good. We've got West Virginia, Indiana, Chicago, Florida, DC, Montana. I always love this. Texas, Missouri, Virginia, Wisconsin, Oklahoma. All right. Well, good. Well, we are 2 minutes in, so I do want to get us started. As panelists have discussed, we've got a lot to cover. So my name is Doug Jutte. Welcome, everyone. I'm a pediatrician and executive director of the Build Healthy Places Network. I'm speaking to you today from New York City on the island of Mannahatta, the original land of the Lenape people. And for those of you just joining, please as well add your name, institutional affiliation, and location to the chat. Build Healthy Places Network is a national nonprofit based at the Public Health Institute in Oakland, California. We work across the country to transform the way organizations work together across the health, community development, and finance sectors to more effectively reduce poverty, advance racial equity, and improve health in neighborhoods across the United States. Today is the next in our series of Network Commons conversations. And as a doctor myself, today's focus is on a topic that's long been an area of interest of mine, which is what is the role of doctors and other clinicians and healthcare researchers in initiating, guiding, and accelerating the kinds of neighborhood investments that make communities healthier, more prosperous, and more equitable for families and children living there. So I'm delighted to have an amazing panel of 4 speakers who you'll meet in a moment. But first, I want to set a slightly different tone. Many of us are on Zoom calls all day, every day, or much of the day. And I want to start off a little differently and welcome our friend and colleague, Hannah Hassan. Hannah is a brilliant spoken word poet, and this is now the third time that she's joined us for Network Commons to start us off. And she's written a piece for us specifically today that she'll present to help bring us together and to launch us into our deeper conversation. So Hannah, please welcome.
Thank you so much for having me. I'm glad to be here with all of you. And I'm just going to hop right into the piece that I have. It's called Imagine a Child. Imagine a child safe at home, chasing brother and sister around the living room. A child discussing the school day from the comfort of the dinner table, lamenting about homework, doing the average, everyday things that a child might do. Imagine a child building a fort in the backyard with friends, riding bikes down the tree-lined streets until the streetlights come on, playing baby dolls and hide and seek, a child laughing, fanciful and free not to worry about the troubles of home, free to not carry the burden of increased rent, of a pending eviction, of elevated electricity costs, of neighborhood crime rates rising, of the possibility that Big Brother is going back into prison, of food insecurity and daily instability, all direct indicators of a life lived in an environment that has been controlled by broken systems. Imagine a doctor, a physician, a medical professional with an internal desire for different, with the understanding that while they might not have all of the answers, that a person like them can help to change these systems, that one intentional act of advocacy at a time, one step towards understanding how to use the resources within their reach, that one meaningful moment of partnership and collaboration can serve as the one beautiful thing that helps to meet the community's needs, that plants a seed of understanding. Imagine a network of healthcare providers and healthcare systems and those with the resources processing and planning and investing in neighborhoods and communities that can benefit from their intentional action. Imagine hospitals using their land to build homes affordable and accessible for those who need it the most. Imagine what might happen to a child, for a child who exists in a community that has been planned for them, that has taken their holistic health into its hands, that gets that when the environment around them is safe and secure, that a child has a greater chance at healing in difficult times, at being lifted up when they might fall, at growing into a healthy, whole human being and not even becoming sick at all. You see, there are children born into our world every day, inheriting problems that they did not create. And those problems might seem overwhelming, but they can still be prevented. Imagine a world where the cure points back to their beginning, their home, their neighborhood, the community that they live in. So imagine making this world a bit easier for them, giving them the chance to be healthy from the start. Imagine how your intentional act of involvement can open up doors for those who really need it. Imagine that world in the beautifully impactful ways that you can play a part. Thank you.
Wow. Yeah, panelists are snapping their fingers. Wow, Hannah, thank you so much. I got chills a couple times, seriously, and it's only the second time I've heard it. So we're going to put in the chat Hannah's contact information, or at least her website, so that all of you can learn more. And amazingly, I only had a single conversation with her and gave her a couple things to read, and she, I think, really captured why we're here. So thank you so much, Hannah. So before we turn to our panelists, I just want to put this work a little bit into broader context. I think my own history is relevant to the doctors and researchers who are listening in. My first job 25 years ago was in a low-income community clinic, and I ran headfirst at the time into what we now call social determinants of health. This is before the term was really being used widely, and really also the limits of my medical capacity to keep my patients healthy, because they were really living in neighborhoods that lacked some of the basic necessities of healthy life. I did a public health degree and a fellowship in population health and social determinants. And it was around that time that I had the opportunity to meet folks in the community development sector, and was really struck by the work that that sector does, focusing on low income and marginalized communities, focused on reducing poverty, strengthening family wealth, improving neighborhood infrastructure. These are the folks that, if you're less familiar with community development, they're the ones that build the affordable housing for families and seniors, and supportive housing for the homeless, grocery stores and food deserts, childcare and early learning facilities in low-income communities, and they invest in small businesses and local entrepreneurs. So they were attacking social determinants of health, but they weren't calling it that. And it was really clear that we in public health and medicine needed to know them, and it would be helpful for them to know us. And that's really where the Build Healthy Places Network came from. And just a word or two about what is community development in the sense of a potential partner. It's a national network of mostly nonprofit, mission-driven, often community-based organizations. There are thousands of them across the country. Some are small, some are national in scale. There are over 6,000 community development corporations, or CDCs. They are mostly community-based, local. There are over 1,000 community development financial institutions, or CDFIs. These are basically nonprofit banks that help weave complex finances together for use at the neighborhood level. There are dozens of affordable housing developers. There are hundreds of asset building organizations that focus on family and individual wealth. They're really in every town, community, neighborhood in the country. And they have access to billions of dollars in federal tax credits and federal grants, things like the low-income housing tax credit, the new markets tax credit, which is focused on creating jobs in low-income neighborhoods. The Healthy Food Financing Initiative pays for grocery stores in food deserts. There's also a giant role for-profit banks, unexpectedly. They are required under the Community Reinvestment Act from the 1970s to invest in neighborhoods from where they take deposits. So it's really an anti-redlining law that leads to, the estimates are $300 to $400 billion a year being invested in low-income neighborhoods, but often not in the holistic, health-focused way that we'd like to see. So there's a real opportunity for this money that really is tackling social determinants for doctors, for researchers, to healthcare, to help guide and accelerate these investments and help define and measure impacts that are most important for health. Fortunately, in the past decade, there's been an explosion of hospitals, healthcare systems, insurers who are partnering with community development organizations, often with doctors, clinicians, and researchers playing a key role. And we're going to hear about some of those today. So I did cover, that's a lot of material there. I'm just covering it extremely quickly, but we'll put a link in the box. My team and I wrote an article that we published a little less than a year ago in Academic Pediatrics, describing sort of the scale and scope, so you can dig into that a bit. So I'm going to introduce now our speakers, our four speakers, and if you could wave, I guess we do have your names and all there. So just very quickly, we've got Kiara Barnett, who's a research scientist at the Center for Child Health Equity and Outcomes Research at Nationwide Children's Hospital in Columbus, Ohio. Andy Beck is a pediatrician and associate professor at the Department of Pediatrics at Cincinnati Children's. So we have a second Ohioan. Tyra Bryant Stevens is at Children's Hospital of Philadelphia, or CHOP for those of us in the field. She's medical director and founder of the Community Asthma Prevention Program, and also chief health equity officer of CHOP's Center for Health Equity. And last, we have Megan Sandel, a pediatrician at Boston University and associate professor of both pediatrics and in the School of Medicine and Environmental Health at the School of Public Health. So welcome all of you. Very quickly, I think most people are familiar with Zoom, but as you know, down at the bottom, there are buttons. One is for Q&A. So that's where you can put questions that'll come up. And we've also gathered your questions during registration. There's another chat button, which is where you'll see links that we put in. And if you have any technical problems we can help you with, please connect us there. So Q&A for questions, chat for other things, and for resources. Last, if you're a Twitter user, tweet hashtag network commons, and our handle is at BHP network, and we'll put some other Twitter handles in there as well. So thank you all for being here. So let's start off with a grounding question for our panelists, just to like, how did they get to where they are now? So you're all healthcare researchers, 3 of you are also physicians in this area of work, focused on poverty and the role of neighborhoods, housing, community development, addressing health. It's not a routine area of focus in healthcare and pediatrics. What is it that led you to this work, and why do you think this work is important? So Megan, why don't we start with you?
Great. Well, thanks for having me today. And I'm really excited to talk more about something that's really important to me as a physician. More and more how I think about how to make people healthier is really by tackling neighborhood level poverty. And so how I came to this work was through my patients, right? So it started, early on in my career with kids with asthma, right? Admitting them to the ICU and really uncovering that they were living in places that were making them sick. And oftentimes I would say, the prescription I wanted to write was for a healthy home, and they didn't stock that at the pharmacy at Boston Medical Center. But, I work now clinically as a co-director of the GROW Clinic for children, kids with failure to thrive. And I can tell you again and again, you're like tearing your hair out trying to get a kid to grow. And then all of a sudden, miraculously, they get off an affordable housing waiting list. And all of a sudden they're starting to grow because they have a place to sleep that's not the living room, and they have a place to eat with their family, and they're not choosing between rent and food. And so I really think that it starts with housing for me. But what became clearer and clearer to me over the years, even doing like a ton of healthy housing researchers with people like Ellen Tone and the Boston Public Health Commission and the Department of Public Health and others, is that you can have a stable, decent, affordable home. And if it's not in a neighborhood of opportunity, you have effectively blunted all of that goodness that stable, decent, affordable home means. And so it really came into, it was like the 4 dimensions, right? It was stable, decent, affordable in a neighborhood of opportunity that was the key ingredient. And so it's how I'll give a shout out to another article that I helped publish in Academic Pediatrics about why we needed to focus on neighborhood level interventions to address child poverty in 2016, because again, it's what our patients are telling us that's necessary for them to thrive.
Great, thank you. Yeah, and that I actually think I've known you long enough. I saw that transition from housing to housing and community simultaneously. Kira.
Yeah, so I came into this work because my background is in public health. And so a lot of my academic training really focused on understanding the social determinants of health. So really looking at a person holistically and understanding not from when a patient arrives at our hospitals, doorsteps, or in our clinics, really looking at what happened to them before they came to that place. So recognizing that housing is a big issue, as Megan already commented, that the neighborhood is also a really big issue. My work really focuses on maternal and child health outcomes. So a lot of the work that I was doing, working with at-risk women who were, at risk for having a premature baby, maybe even experiencing a death of an infant before their first birthday. And a lot of the work really kept coming back to this issue of not having stable housing. So we want to get moms in the clinic for their prenatal visits, and those things are really important to outcomes. But what's also really important is that she has a place to lay her head, that she knows where her food's going to come from, that she knows that she has a safe space for herself during her pregnancy, but also once the baby enters into this world, where is the baby going home to? And so really needing to kind of focus on and look at all of those different aspects of a person's experience to improve health outcomes for our population, and happen to have come here to Nationwide Children's within the last year, and thankful to be at an academic medical institution that's also really embedded in community and doing work in community to address some of these important issues.
Great, thank you. Tyra. Oh, you're on mute.
Good afternoon, everyone. Thanks for joining us. I'm happy to be here. I'm a primary care pediatrician, and so I came into this work at a time when I was medical director at an inner city office from CHOP, where we were providing really guideline-based asthma care. But despite that, our kids still went to emergency room and hospital. So we started just going out to the community. We had community classes, and we started listening to the parents and what their barriers and what their struggles are. And then we really organically designed our program to meet those needs. So as part of that, we went into the homes with community health workers to provide education and environmental mitigation. But over the years, we realized that even with that, and we saw improvement in their outcomes, there was a level of house disrepair that we were not addressing, and that really impacted children's ability to sleep, to eat, to play, as the other speakers have talked about. So about 4 or 5 years, I guess it's close to 5 years now, we started doing home builds, where we actually go and do renovations in the home and do structural repairs to reduce the root cause of triggers. So we know moisture is a contributor to all the triggers for asthma almost. And so really addressing how we have a tight building is where we started. Then evolved to my role now as Chief Health Equity Officer, and we're doing neighborhood place type stuff where we're thinking more broadly, as Megan and what Kara alluded to, is how do we really think about holistically what impacts the child. And I think as a pediatrician, every day when they come in to see us, we spend more time talking about social determinants of health than we do about the clinical health. And so really trying to tackle those issues more broadly and holistically around each individual child.
That's great, Andy. And yeah, it's funny. I'm just thinking about the word holistic. I mean, that was not my training in pediatrics back in the day, right? So it's really lovely. Andy, tell us about University of Cincinnati, or your arrival in this work.
Yes, thank you, and really excited to be here with some people I admire very much. So it's exciting to be on this panel and already inspiring some of the words that we've heard. A couple central themes that I think you've already heard a bit. One, the importance of place, and another, the importance of learning from our patients and our families. And I'd say the way I really gained entry into this work was through a formative experience I had during my training. I was a pediatric resident working in the emergency department late one night. I was one of the residents who was on the response team. So if a very sick child came through our door or a trauma came through our door, we would rush our way to the trauma bay and respond in kind. And so this night that pager went off, we rushed to the trauma bay, and the school-aged child was there presenting with really horrific asthma, had developed work of breathing very quickly, very rapidly, rushed by squad. And in the ensuing 20 or 30 minutes, we tried everything we could. I was on chest compressions after this child went into arrest, and this child died right there in our emergency room. And a few of the things we would learn later was that she came about a mile from her home, from a neighborhood in the shadow of our institution, a neighborhood characterized by low quality housing, threats of eviction, all the things we heard in the poem at the start, a business district decimated by decades of disinvestment, all things that likely contributed to the reality that this child showed up in our emergency room in extremis and not in our primary care centers, well and thriving. And I'd say in the years that followed, the importance of place became a central theme, highlighting that morbidity and in some cases mortality varied considerably by neighborhood, and not just for asthma, but for essentially every condition you might put to the test. And it became this thought in my mind and the minds of many of my collaborators, colleagues, and partners and friends all across our city here, that if neighborhood can contribute to morbidity and mortality for a child, so too can neighborhood contribute to a child's ability to thrive and be all that they can be. And so I think it's been that journey from understanding the negatives of what a neighborhood can contribute to the positives of what they can contribute that really colors our work to this day.
Yeah, great, thank you. Yeah, it's the story, as you said, is really taking the poem that you heard and bringing it to a specific instance. So now I'd like to turn to sort of a little bit the broader picture of the work of your institution and your own work. So, our focus is on the role of physicians, healthcare researchers in advancing these types of community investment. Can each of you tell us a little bit about the work that your institution has done around this type of area, and what role you had, or what role your clinical and research colleagues may have played in some of this work? Tyra, why don't we start with you?
Sure. As I was talking before, we decided that we wanted to actually partner with one of the home repair agencies, nonprofit home repair agencies, and we had many discussions at community meetings, but really didn't see a way to do it. And then discovered the Build grant, where we were able to demonstrate that a healthcare organization and a nonprofit could work together to individually repair homes for children with asthma. As our institution saw that we were able to do this and sustain this, they became interested in it, and they now invest in it. And not only that, you spoke of the bank investments. We just received a $1 million grant to do block bills. So now we're not just targeting the child with asthma, we're targeting the whole block. And our plan is to do that neighborhood by neighborhood in West Philly and then the rest of Philadelphia. In addition, CHOP has invested funds in a kind of a unique community center where we have both an adult, the public health department clinic, a primary care clinic for pediatrics, and a library and literacy center. And that's really brought kind of the family together and opportunities, and there's a huge playground. So really thinking about how we do multidisciplinary and how we holistically think about this. And we do this through not only community investments, but also philanthropic. So I would say that our foundation has been really active in pursuing opportunities for us to expand and really, and this, in my new role as a chief health equity officer, I've found that, people are open now. People are willing to give and to really, when you have something that has some evidence and that you're measuring, you have metrics, that they are willing to really invest in now. And we are getting more investments from both private and corporate donors to do this work.
That's really great. And my team is, so by the way, Ashley Hernandez and Kevin Leacock and Laura Capallo are in the background and helping us and putting in some resources for you all. So each of the speakers has provided us some resources for folks to look into. And the last one on the list we just pasted into the chat box under Tyra is actually a case study we did on the CHOPS, Children's Hospital of Philadelphia's investment and role in creating the Community Health and Literacy Center in South Philadelphia. So thank you very much, Tyra. Andy, I think I've got you next. Yeah, Andrew.
Yes, thank you. So the place I'd like to start with answering this question takes us back about a decade or so to a lot of our early community and population health work that was really modeled after much of what was done in the decades prior at Boston Medical Center. And in fact, a lot of our early efforts focused on the importance of building, sustaining, and enhancing clinical community partnerships. And perhaps our most notable or successful partnership to date has been our medical legal partnership called Child Health, which is a partnership between Cincinnati Children's and the Legal Aid Society of Greater Cincinnati, where advocates, attorneys, paralegals are co-located in our primary care centers and help us to have a ready resource to confront issues like housing instability or adverse quality, public benefit denials or delays, educational impediments. And over the years, we've seen this partnership grow into a partnership that fields 800 or 900 referrals a year, that positively affects legal outcomes for low-income patients and their families, that has led to measurable increases and enhancements in housing quality, more than $1 million in public benefits received, and many hundreds of pediatric trainees who learn from experts in the field. We also recently found that connections to this legal aid partnership result in a 38% reduction in the rate at which kids are hospitalized in the year after referral. So meaningful health outcomes too. Now take those clinical community partnerships like with legal aid, additional high functioning partnerships with our local food bank, with public health, with schools. And about 5 or 8 years ago, we built something called the All Children Thrive Learning Network, which can be resourced at the URL actcincy.org. All Children Thrive is a Cincinnati-wide learning network that brings together key agencies, organizations, individuals, patients, and families to center on children, families, and communities, and understand what it will take to achieve measurable impact to help children to thrive. And just notably on this, and relevant to the conversation that we're having today, that included at that table are members of our city government, the Avondale and other community councils and community development corporations, to try and think about where those investments could take hold to build better, healthier neighborhoods through these meaningful community partnerships.
That's great. Yeah, and it sounds like you might be a fan of Megan Sandals, given her history in the some of that work. I think, Kara, did I have you next?
Yep. So yeah, here at Nationwide Children's Hospital, we have initiative called Healthy Neighborhoods, Healthy Families, which started way back in 2008. And the initiative, one of the big focus areas is housing, but it also has these other kind of high impact areas that we want to also target within communities. So we're looking at education, we want to look at health and wellness at the population level, want to do some community enrichment activities, and also some economic development within neighborhoods. So if we want to focus on our housing kind of metrics and kind of what we've done over the last 14 years, approximately we've had about 600 housing units that we've touched through our initiative, and it's been about $60 million of investment over that time period as well in the housing initiatives. And so some of these housing initiatives, some of them are full gut renovations of homes, new builds to create some more energy efficient housing units as well. And then we also have a grant program for current residents if they need to do some home repairs on their home that they can apply for as well. And then over the next 5 years, the goal is that we're going to increase the number to add an additional 500 units with another $50 million, or sorry, not 50, 70 to $80 million of investment within the community. So we've started on the south side of Columbus, and that's kind of where our hospital is located, our main campus. And then we also, in the last, I think, 2 or 3 years, have started to do some investment within our Linden community. Both communities are predominantly Black communities that have been historically redlined. So we've seen a lot of historical disinvestment within these communities that have led to the inequities in the resources, also the health inequities within those communities. And so really trying to pour investment into the communities to kind of see a difference and make a difference in the health outcomes. So from the research perspective, we've done some research to look at, what's the impact of the investment dollars that have went into these communities. And so our research team has found that we do see an impact on healthcare utilization. So when we look at our South Side community, for example, which is where we've done that research on a South Side community, comparing it to a community that's comparable and the demographics and some of the other landscapes within the community, we see a decrease in ED visits and hospitalizations within the community. But then we also see some improvements in lower homicide rates, lower assaults and robberies that occur within the communities as well. So we're seeing both the health impact, but also different social impacts of our investment. And recently, our center here under Dr. Dina Chisholm was awarded a multi-million-dollar NIH grant. I'm super excited about that work. That work is looking at structural racism and its impact on maternal health outcomes. And it's really rooted in this investment that we're doing within the Linden community here in Columbus. So we are going to be talking with women to kind of collect their histories of how their perinatal experiences across multiple generations of women who have lived within the Linden community. We want to use a method called opportunity mapping. So we're looking at the changes in social determinants of health over the community and how do we map their narratives with those changes and outcomes. And really the whole purpose of that is then how do we take those two pieces and how do we package them in a way that when we communicate with the investors who are making decisions, that we can also hopefully influence their decisions and in order to rectify some of the, again, historical and contemporary injustices and disinvestment that's happened in these communities, and in order to improve health outcomes. So that's some of the work that we're doing and that we're really excited about here at NCH.
That's fantastic. Yeah, thank you so much. And again, for folks that are paying attention, we've been pasting some resources into the chat box. And importantly, there's a number of peer-reviewed articles that have been coming out of this. It's taken and those of us here on the panel know how hard this is. This, demonstrating neighborhood level impact is really complicated. And so there aren't a lot of pieces, and many of the people here on this on the screen right now are the ones leading the research to support this. So Megan, tell us about your work in Boston.
Yeah, well, first of all, thank you so much. This is like the all-star panel of institutions that are leading the way here. So just want to again give a shout out to Cincinnati Children's, Nationwide Children's Hospital of Philadelphia, just amazing work. I just want to think on the Zoom with you all around how do you make patients healthier? And we focus a lot on individual level interventions, but I want us to think about the bidirectionality that you've now heard from multiple institutions, that by focusing on places and making places healthier, you can actually measure individual level benefit just as much as you can use individual level tracking to look for what are place-based trends for impact. And so what I'm wanted to lift up for Boston Medical Center is I'm a pediatrician. I went to medical school, but like Doug, I heard about this sector called community development about probably now 7 years ago, and joined a board called Enterprise Community Partners, where I started to learn about investing. And so one of the cool things that in 2017 that we heard about in Boston was the Healthy Neighborhood Equity Fund. And I got confused. I thought it was a fund about health equity. No, equity funds are financial products. They are where you place investments and equity in building things like affordable housing, grocery stores, et cetera. And so what was differentiating about this fund was the fact that they actually did financial scores on each investment, and then they did health impact scores. They actually did health mini health impact assessments using a methodology to say, this investment not only is a great financial investment, we'll get our money back, but it has a grocery store on the first floor. It's in a walkable neighborhood with transit. The building is going to meet certain green criteria. And every investment had to meet both a financial score and a health impact score to get invested. And I will just note, like, we as a hospital, we're doing kind of our first kind of place-based investing initiative in 2017. And we went to our chief financial officer and treasurer, and we were like, we want to invest in this fund. And I need to give a shout out to my compatriot in this work, Vice President of Mission, Dr. Thea James. And we went and they said no. And then we asked them to consider it again, and they said no. And then we asked them a third time, and they said maybe. And one of the greatest things, and I just want to give this again, I think everyone on the panel will agree to this, is that when you get out of your four walls of your clinic, and that includes your finance staff from your like treasury and your investment portfolio, and they actually visit the neighborhoods and see them up close, that was the moment where our treasurer said from maybe to, yeah, I'm going to start to sell this. And for us, it was a really exciting thing. We were the first hospital to invest in this equity fund. Since then, Dana-Farber Children's Institute has invested and United Healthcare has invested in it. And so this idea that like we have tools in our toolbox that are more than just patient care. We have actually balance sheets that can show up in ways to create healthier neighborhoods. And so I'm just really proud of that as like another tool that we can start to do that bi-directional patient experience to place-based experience and being able to see that impact.
Mm-hmm. Yeah, thank you so much, Megan. That you summarized a lot in a short period of time, and we'll put some links in. But I do want to just reiterate something that Megan said, is that hospitals have investment portfolios. So this was not community benefit dollars. This was out of their investment portfolio that any large corporation has to have to pay payroll and whatnot. And so it's an investment, and that you can also do this through loan funds. There are many ways in which hospitals are doing this work. So let's hop to the last question before we go to Q&A. And this is just something my observation has been that I have run into skepticism before about doctors even doing this work. The tackling poverty, the intervening at the neighborhood level is beyond what healthcare should be involved in, beyond what doctors should be involved in. It's not a role we should be playing. So how have you guys run into this, and how do you respond to this question? And for those in the audience who presumably do want to learn more and not follow that advice, where might they start? So how do you respond to this resistance, and what could someone do next? And I think Kiera, I believe we're starting with you.
Okay. Yeah, I think that kind of reiterating some of the points that we've all touched on thus far, I think it's really recognizing that, you know, we have to approach this holistically. If we want to have a major impact, a larger impact on, again, not just our patients that we see, you know, every day, but if we want to have a population level impact, we have to have population level solutions to the work that we're doing. And I think it's also recognizing that we don't live our lives within these particular silos. So, you know, we need to address kind of every layer or aspect of people's daily lives in order to see the impacts that we want to see at a larger level. So I think it's really getting people to kind of look at our health and population a little bit more holistically. So it's one of the things that we have to do, one of the challenges that we have to overcome. So we know we've all probably seen that diagram or a version of the diagram of social determinants of health that really talks about, you know, that health is 20% clinical, you know, 80% social determinants of health. So if we want to have positive impacts on our patient populations, we have to care about that 80%. We can, you know, give it our 100% to that 20%, and it's not going to be enough. So we have to really push ourselves to think beyond our individual patient care and really into a population health and social determinants of health lens to the work that we do.
Super, thank you, Kara. Megan.
Yeah, I think we've talked a lot about kind of this idea of, you know, individual level interventions, systems level interventions, and now we're talking about like place-based interventions. And I think there's like one more level we have to talk about, which is policy. And so much of why certain neighborhoods are the way they are was a policy that was designed in the 1930s that decided which places were of value and which got better rates and who could invest in there. And so I will give, thank you so much to Laura and Ashley to put in the 3 articles that I wanted you guys to know about. And one of them is really like, what are the root causes of why neighborhood level poverty is playing out? And it is structural racism. And we have to like be super fluent in how we talk about that and name it and talk about it, because the social determinants are not by accident. They are not natural. They are planned and designed and perpetuated in every decision today, unless we are as intentional in undesigning them. And I think that that's a unique role we, as doctors, as frankly pediatricians, play a role, is bringing our voice to that in zoning decisions and allocations of resources and how we invest in grocery stores in neighborhoods that wouldn't otherwise get them. And those are all really important, I think, ways in which we can show up to the work. So thanks.
Mm-hmm. Super. Well, good. We're actually doing okay time-wise. And in fact, we're getting a lot of great questions. And I know already we won't be able to get to them. But if any of our panelists see one that they feel like they can answer in the Q&A, by all means, go ahead. But we'll go ahead and turn to, we also got some during the registration process. So just to sort of flip this on its head a little bit, I thought an interesting question we got from the registration was, what advice do you have for nonprofit affordable housing developers who want to attract investment from healthcare? So it's from the other direction. What might any of you, and I may direct this at you, Megan, but affordable housing developers listening to this saying, gosh, these hospitals in these 4 places are doing amazing work. Who do they talk to? What do they say? Any thoughts? Maybe Megan, start with you, but if anybody else has ideas.
Yeah, so I recommend affordable housing developers to ask 5 questions when they are recertifying their residents. I always want to say patients, but their residents on an annual basis. So the first is, where do they get their health care? Who insures them? How many times have they been hospitalized in the past year? How many times have they gone to the ER in the past year? And what chronic diseases are they facing that they would either like help with or that they're facing? And the reason I say that is that those 5 questions will tell you about the burden of disease and how many people are like having potentially avoidable healthcare utilization and who your natural partners are. And so there are some affordable housing developers, like the community builders do annual surveys. Some of the other big, Mercy Housing, Preservation of Affordable Housing, and others are doing some of this data collection. But I feel like those are the 5 key questions that tell you whose door you should be knocking on.
That's a good point. Anyone else, anything to add? That feels good. And interestingly, by the way, I know, Megan, you mentioned being on the board. Another way that physicians and researchers can play a role. Megan was on the board of Enterprise Community Partners, which is one of the largest of these nonprofit affordable community development financial institutions. And I've been sitting on the board of Mercy Housing nationally, which is the largest nonprofit affordable housing developer in the country, as a doctor. There's actually a second doctor on the board now with me, but it is a role that one can play to actually guide sort of strategic planning and stuff. So another question that came in, which this is directed to the 3 physicians of the group, is how do you balance your clinical practice with your policy work? It feels very like a very practical question to me. Any thoughts, Tyra? Start with Tyra or Andy.
Yeah, I mean, I think I've been doing this for about 30 years. So now the question is, how do I balance my clinical work with all the other work that I do? So it has flipped, but back in the day when I first started this work, I'll be honest, a lot of this work I used to call the second shift, the second mommy shift. Once I put the kids to bed at 9 o'clock, I had 2 hours to work before I had to go to bed. And so a lot of the things that it does take some after hours, but I do think it's important to identify those folks who are on the same path that you're on. So for example, for me, it was not initially housing, it was really just trying to understand what was going on. So I joined, there's the Allies Against Asthma group in Philadelphia, which I joined. It was all the hospitals and just understood the lay of Philadelphia, which I really didn't know. It was before the day of big data where I could have just found it really quickly and began to voice kind of my concerns and try to be a part of the solution. So I think it's always important to work with other people. And I think Kiara mentioned silos, and I think my whole life has been around breaking down silos and making sure people are talking to each other in the nonprofit. When I first started this housing piece, the hospital didn't do housing. We're not contractors. That's what I kept getting. We're not contractors, but really working with a local organization to identify one truck contractors, getting them certified. So we use only minority and women-owned businesses, just really trying to work grassroots. It does take getting your hands dirty, and it's not always comfortable, I don't think, but I think to get to the policy level is always important, but you can't just stay there because we know there's a whole lot of policies that nothing's happening, right? We have LNI violations out the roof and nothing's happening. We still have really poor repaired homes. So I think it takes both, always keeping your eyes on the policy, but realizing that it doesn't always trickle down to the folks who need it the most, and being a part of the solution however you can.
Mm-hmm. Thank you. Thank you. Andy, how about you? You're seeing patients. Does some of your time get covered by others? How do you balance clinical?
Yeah, it's an interesting question, particularly for those of us in academic medicine. My weeks each day looks very different.
Mm-hmm.
In terms of my FTE, my full-time equivalent, some of it is clinical, some of it is research in fairly traditional funding type mechanisms that I've shoehorned into this type of work. And then other aspects of my funding are investment by our hospital in community and population health there's long been this idea of return on mission. I think it was Megan who kind of alluded to that concept before. But we are also now starting to advance focus on return on investment. This idea that we have accountable care per member per month type contracts with Medicaid providers, which is a relatively new thing in our part of the state. And we're trying to figure out what that looks like and how we might be good stewards of that investment to achieve health and well-being with the patients who are insured through that mechanism. And I think that is opening up some new doors for both how my personal time is funded or how people like me get their time funded, but also for innovations that before were hamstrung by insufficient resource and were done between 9 p.m. and 11 p.m. on everybody's clock. I think we're starting to enter this world where there's this better alignment of return on mission and return on investment that's making it a little bit easier, at least for some of us, to advance conversations in spaces that perhaps weren't as open before. I do think, as I mentioned, some of my time is grant funded. And I will also say that there seems to be growing interest in certain federal funders or foundations for this type of work. I still think that is a slow field, or I still think those sources have been somewhat slow to latch on to the importance of this as a set of concepts or set of research questions. But I'm optimistic, perhaps more so now than before, that there will be more opportunities for those who are interested in research, population health research, social determinants research, neighborhood, multi-sector, innovative methods that may have had a place in social sciences for years, but have been a little bit more difficult to open up in biomedical research. I think there are more opportunities now, and ideally will be more to follow.
Yeah, and your mention of incentives, I know Nationwide Children's Hospital in Columbus is part of an ACO, Accountable Care Organization for Children, and that switches the focus, right? Because you actually want to keep children healthier in a way that a normal healthcare system may not actually be incentivized for. Megan, any comment for you in terms of how you've balanced this work and your clinical work over the years?
Yeah, I do think it's about teamwork, right? Nobody does this work alone. And so for advocacy work, get to know your government affairs staff at your hospital or health system. They're your best friends. They are the ones that may not know about housing, and they want your help in understanding it and how to go and make relationships. And frankly, that can be, again, an extension where you're not doing it on your own, you're really working as a team. So that's the first. I do think, to an extent, figuring out a topic that you want to be an expert, right? Like, can be, this is a big field. And so if you're interested in food justice, great, dive in on that and start to figure out who are your natural community partners. I think, this is about coalition work and really being able to work with those key community-based organizations where you may be able to contribute a quote to their press release or make yourself available to the media and use, maybe you co-write an op-ed where they do most of the writing and you just do the light editing. Again, it's like, teamwork is the dream work here. And then, yeah, I used to joke, I did research to protect my time to do the work I really wanted to do, which was advocacy. And that's not always open to everyone. And I just want to acknowledge that. But I do think more and more, this track of being an academic advocate is more and more acknowledged and open, and you can become a teacher of advocacy. You can become a, innovator around advocacy. You can start to build clinical innovations around advocacy in ways that I don't think was open to many of us maybe a decade ago.
Mm-hmm. Yeah, that's really helpful. Thank you. So Kira, there's a couple of the questions that have come in that I may direct at you first as our little more intensive researcher here. So one has to do with, what outcomes are measured to track improvements in health. Another is and again, I'm sort of just throw a few at you, maybe you can just give your sense of things. What progress has been made in terms of getting some of this information into electronic health records? Whether you've seen that or maybe more broadly in the field. And again, another one was related to, have you established success indicators related to neighborhood improvements that connect the health of, as you said, Megan, the health of individuals and the health of communities? So it's kind of a data question generally, Kara. Any big picture thoughts there?
Yeah, I think a couple of big picture thoughts. So I think one, so I'll start with like, how do we measure success and health outcomes? So I think you can approach it a couple of different ways. So one, you got to remember that, again, we're looking at neighborhood level conditions. So we want to look at neighborhood level outcomes. So if we want to point back to I think the paper that we dropped in the chat earlier that looked at healthcare utilization, we were looking at, if we look at a pool of patients that come from the community that was targeted for intervention, what are some of the healthcare utilization in that community in comparison to a different community? And we just looked at health utilization overall, measured by ED visits and hospitalizations within patients. Some of the work I mentioned, the NIH study that we just got funded, that work, we're going to be looking at the overall prematurity rate within the Linden community compared to a separate community. So again, we're not necessarily looking at our patients at NCH and what are their birth outcomes. We're looking at for all babies born in this Linden community, whether they've come through our hospital doors or not, are they being born, on time and of a healthy weight? So it's shifting how we're looking at the outcome, how we're measuring the outcome to, again, be that population focused. So I think that's the first thought in terms of how do we measure the health outcomes? How do we measure success in have we addressed social determinants of health? That one's a little bit more tricky to measure. So, it takes a long time. And I think that's one of the things we have to recognize with this sort of investment. To see some of those neighborhood level shifts in social determinants of health is going to take some time. As Megan already alluded to, we've come to this place not by accident, but through generations and generations of injustices within our communities. And so it's going to take us some time to see the difference. Some short-term things is we can look at individual, what we call social needs, right? So it's not necessarily, what is the education level or poverty level within the community, but for our patients coming in the door, do we see differences in the rate of patients who report that they have food insecurity or that they, are housing unstable? So that's a kind of immediate way that we could look and see, do we see changes? There's no it's not an easy population level survey. You can do a population level survey of communities to see what changes you see in those needs over time. But that's kind of, I think, one of the easiest way to see if we see changes is now to say, okay, within folks that we see coming from this community, do we see shifts and changes in the social needs that we're reporting? But that means we have to be collecting the data in the first place. So we have to really ask folks, what are they experiencing, and then tracking that over time.
Mm-hmm. Yeah, and I think you said something here that is important to note is there's the social needs, the immediate social needs, and those, we need to see evidence that those are improving, but that's not necessarily tackling the actual determinants that led a family into the tough situation they're in. And so it's kind of a both and. And so the longer term, you need short-term proxies for the longer term health outcomes that may take years to decades to even show up. Other experience from the rest of you in terms of outcome measures or electronic medical records?
I'm happy to jump in just briefly. A couple of things that we do routinely here, and I'm certain other places across the country either are doing or could do, is think about how to display data to advance the importance of equity as a key part of all that we should be doing. And I would say a neighborhood focus is one that has been consistent, that we now pretty routinely look at hospitalization rates by neighborhood, ED visit rates by neighborhood, across conditions, across causes. And we do so for a couple of reasons. One, to understand what the equity gaps are across our center, across our region, but also to bring new partners into the conversation, including within the health center, so that this is not a movement just found in general pediatrics or just found in emergency medicine, but the same equity gaps are there for diabetes and for injury and for bronchiolitis. And so all of a sudden that forces the hand of others to come into the conversation and think about what a population health approach could be that is truly across the board. We've talked a lot about using these types of data to advance a culture of equity that matches the culture of safety that has long been at the core of what Cincinnati Children's strives to be. And to get there requires that we do some important things in our own shop, but also, of course, that we connect with those neighborhoods and families that live within them. One other thing I'll just say briefly, pertinent to the social needs conversation, is that I know a lot of places are now integrating social needs screeners into their electronic health records. And that's something we've done for some time. Lots of places have. And so there may be, for those who are interested in learning more about that, I'm sure there are resources we could connect people to, including tied to certain health record companies like Epic or Cerner that have some off-the-shelf type tools that people could use.
Great, thank you for that. Well, I can't believe it. The time is almost up. So there are so many other good questions. I've seen questions about gentrification, about connecting to school systems, about connecting to community clinics, about connecting to food access folks there, and we just don't have time. But I do want to give each of you a few moments for any closing comments that you'd like to make before we go. And so Tyra, why don't we start with you?
Yeah, so I think this has been really great. Every time I'm with a panel such as this, I learn a lot. So I've learned a lot again. And I think, my closing comments would be that, neighborhoods, place, and individual, they all matter. And we can't all do everything. So whatever is your passion, whatever is your gut, that's what you should work with. And that's where you should start.
Great, I like that. Andy.
I think I would close with a statement of what the Cincinnati Children's vision is, which is to be the leader in improving child health. And nowhere within that clause or within that sentence is the word healthcare. And so this requires us to think more expansively about what truly it will take to improve health and do so equitably.
That's really lovely. Kiara.
Yeah, I think one, just echoing what my co-panelists have already said, but also I think it's just really want to emphasize emphasize the power and the need to collaborate with other people in this work. As Tyra said, we can't do it alone, but we have to figure out what are the win-win situations that we all, like, how do we align our goals together in order to improve neighborhoods and ultimately improve the health of our communities.
Wonderful. And Megan, last words.
Yeah, I think that in many ways this can be overwhelming. So start somewhere. Like, you can do it. Don't take no for the answer. This is about changing kids' lives, and what better way than to put together the 2 or 3 sectors that can make a difference. And so I'm just really excited that you all were here for today, and thanks for your attention.
Great. Well, thank you. I want to thank all 4 of you. I also want to thank Hannah Hassan, who spoke at the beginning. We'll make sure we get that information out. We will send out a follow-up email for everyone who's registered. There's also a survey to tell us what we're doing well or not, and we'll send that out by email, and it's in the link. And thank everybody for joining us today. And again, thank you to our speakers. It was really fantastic. Appreciate it.